Because this is an interaction session, we're going to start with Professor Reyes from the University of Strasbourg. Professor Reyes, can you hear me? Bonjour.
Yes, I hear you. You're very well.
Bonjour, ça va?
Ça va, merci beaucoup.
Okay. So, Professor Reyes, we're going to present us about his work. So, Professor, you have 10 minutes to present. Thank you. We are welcome.
So I'm very delighted to be invited by the organizers and by yourself. I wish also to thank Dr. Kanyabu Tembo for her kind invitation to give this talk today in the ERCAD of Kigali. And I know that you have a very close connection with the city of Strasbourg and the University of Strasbourg due to Professor Jacques Marescot. So today I will address some specific neurotoxicology issues, and I think it's very interesting to share with you some of my concern about neurotoxicology. As you know, neurologists and oncologists are often related, and today I listened at the first session, and I can say that it was important to consider also the brain and to consider the environment, and two of the speakers have addressed this issue. At first, I wish to let you know, and the interaction between the environment, and we have to deal with environmental factors when we consider the brain as well as when we consider cancer. Neurotoxicology and neurotoxicant agents are often the same as the agent which are involved in the cancergenicity, and they are acting very different ways, and we will see these ways which are genotoxicity and other ways that implies, for example, endocrine disruptors. I will comment also this next slide, which illustrates the impact on human of the global pollution. And I think it's a very important message to consider the global pollution. I have adapted these slides from Philippe Grandjean and Philippe Landrigan, Danish and American researchers, who showed that at the beginning, when you have neurotoxicological impact of the environmental and chemicals, it concerns only few people, and it will involve the whole population. And now we are here on diffuse and global chemical contamination, and this is very important to be aware of. And you see also that when we consider the dose is very low at this stage, but it's diffuse, but the number of people exposed are very high. And it's occurring, of course, in the westernized countries as well today in Africa for several reasons which are out of this conference. Next slide, please. When we consider this global pollution, we have first to consider air pollution. I do not know this part of Africa, but I think it is very important to consider the quality of the air. And everywhere you have a pollution related to chemicals, and this pollution is also coming from different areas of the Earth, because air pollution is vehiculated by a jet stream and can deposit everywhere around the world, for example, in the Arctic as well in the Antarctic. So Africa is also exposed to air pollution coming from Asia, probably, or from Latin America. Air pollution is very complex, has a very complex chemical composition, But anyway, it's important to know that for the WHO, air pollution was the cause of 9 million premature deaths. Of course, next slide. And these deaths are related to cancer, as you see, stroke and heart disease. So we share the same cause of stroke and cancer, air pollution. This is my very important message, considering the action of inflammation, which is not absolutely not acting by genotoxic ecological effect. Next slide, please. Here's another example of the importance of chemicals around the world. And some of these chemicals have some special properties, and they can modify the endocrine system that are called endocrine chemical disruptors. And these disruptors you see on this slide can provoke cancer, prostate cancer, breast cancer, but also have a very important impact on the brain and lead to brain alteration, specific modification of the behavior, and so on. So you have, next slide, please. So we have a different action. It can be also an action which do not use the genotoxicity of the molecules. And you see here that in the case of endocrine chemical disruptors, the action is related to hormones which modify the neurodevelopment, which can modify the expression and the growth of cancerogenic cells. Next slide, please. Here you have another important thing, which is the difference and the modality of action of a molecule. And it was shown by my colleague and friend Peter Spencer, who showed very clearly that the MAM, this methyl azoxymethanol, was able to damage DNA. And depending on the cells, the effect was or cancer or neurodegenerative disease. And this shows also that it is very important to consider the action of chemicals, which may be differ depending on the type of cells they affect. Cyclin cells, it leads to tumors. Affecting non-cyclin cells, it can lead to cellular degeneration. Next slide, please. So I would also emphasize the role of all the chemicals used in cancer, and you have heard before that they act on the brain and on the nervous system. So it's very important to consider that all chemicals, all used as a medical agent, may act on the brain and the nervous system and have a deleterious effect. So it is also important to consider preventing such side effects, even if people are cured from their cancer. Next slide, please. So I will end and emphasize three very important messages. We are living in a global soup of chemicals everywhere in the world, and this global contamination is very important to consider, because it is possible that these chemicals have action on our cells and our brain, and so by two ways, genotoxic or not. And the last message is that all chemotherapies are neurotoxic. So even if it's not a message of treatment, it is important to consider this for prevention. And I think also, as well as for cancer, as for neurological diseases, the first step before treating is preventing. Thank you much for your attention.
Thank you, Professor Reyes, for the great presentation. I have a quick question, a quick one. In what ways do neurotoxical side effects of anti-drugs impact on patient outcome, impact? And I would like also to know what innovation treatment to mitigate do you use mostly in France?
So it's a very interesting question, but I think all kind of chemical drugs have an impact on the nervous system. They can, of course, you know very well neuropathies which affect the nerves, but it's also very important to consider what is called a chemobrain. And in some cases, you may have, I gave an example for a cerebellar syndrome related to the exposure and the use of some treatment, aracitocin C. And in this case, the side effect was related not only to the drug, but the use of this drug, and the condition of the patient was she had insufficiency of the renal insufficiency, hepatic insufficiency, and you know sometimes you have more vulnerable patients. So when using any drug for cancer, the first should be to consider the condition and the capacity of the liver as well as the kidney to evacuate and to metabolize all these drugs. Because this is a very important point. When you do not consider this, you increase the side effects. So second aspect, and so it's very important, and in this case, my colleague oncologist learn how to prevent the side effects by having a perfect metabolism of this of the chemotherapy drug. This is the first step. The second step is, of course, providing sufficient oligo-elements and vitamin to also increase the ability of the body to metabolize the chemotherapies. I think it's very important to consider these 2 points in a very practical point of view. Thank you for your question.
Thank you, Professor Reyes. I will ask you to stay online because maybe part of the audience people will have questions. Let's move to the second panelist. We would like to welcome Wize Edulene. Wize Edulene, she's a survivor of cancer, and we would like to know from your experiences what was the challenges from the diagnosis. I mean, a little bit about your journey and what was the challenges, and what kind of intervention was was helpful to part of your journey. So Mrs. Wize, you're going to speak in Kinyarwanda, so people can use the earphone for translation. Thank you.
Murakoze, nitwa Uwizeye Marie Edulene, nkaba nararwaye kanseri y'ibere, breast cancer. Nayimenye mu 2021. Nagiye kwivuza nkuko bisanzwe, nta kibazo mfite, ari check up ngiyemo isanzwe. Ngezeyo umuganga wankurikiranaga aza kureba, mwereka ibere, arebye asanga harimo ikibyimba, ahita nsaba kwihutira kujya kwisuzumisha mu buryo bwimbitse. Nagiye Kanombe, banyohereza Roi Faisal, nkoresha biopsy, basanga harimo kanseri. Nkimara kubyumva byaragoye cyane, ntabwo byoroshye. Ubundi iyo inshuro nyinshi iyo numvaga kanseri numvaga ari nkaho uhise upfa, ndetse n'abandi benshi niko babitekereza. Ariko abaganga baramfashije. Muri nge natekerezaga, nibazaga ukuntu abana bagiye kubaho kandi narabarihiraga ishuri, nkibaza akazi nkora ko ngiye guhita nkavaho, nkumva biragoye. Ariko abaganga baramfashije, banyumvisha ukuntu umuntu afata imiti iyo kanseri ikiri hasi, hanyuma agahita akira. Narabikoze koko, ntangira chemotherapy, nayifatiye hariya i Kanombe muri Rwanda Cancer Center. ntangira chemotherapy baramfasha cyane narayisoje noneho bankorera surgery barambaze uko mundeba uku nguku mfite ibere rimwe iryo ririmo kanseri barikuyeho ariko nari mfite icyizere gikomeye cyane ko ngomba gukira nivuje muri njyewe numva ngomba gukira uko byagenda kose nubwo muri sosiyete byabaga bigoye kugira ngo abantu babyumve abantu benshi baranyegeraga ugasanga bari kagabanyutse kuko ugenda ukora ukurikije uko imbaraga zawe zingana urumva rero nabwo ibyo ngibyo byagiye bimbera imbogamizi ariko ndashima Imana ko byagiye bigenda neza ari abayobozi ari family ari abo dukorana ari abantu b'inshuti zanjye bose bamba hafi rwose ubu ngubu ndi mu kazi bimeze neza ngira ngo murabibona ubundi iyo wafashe imiti ya kanseri n'umusatsi uvaho ariko umusatsi warongera uragaruka murabona ko ndi umuntu umeze neza mfite imbaraga rwose zihagije akazi ndagakora nta kibazo murakoze cyane nyakubahwa ndumva
Murakoze cyane Wizeye. I have a second question. Niki wumva society yacu igomba gukora igihe babona umuntu afite arwaye cancer? What is your advice you think our society can do when they meet someone with
Murakoze cyane. Umuryango nyarwanda ukwiye kumva ko umurwayi wa kanseri nawe ari umurwayi nk'abandi. Ikintu cya mbere burya bakwiye guhumurizwa abantu bakamuba hafi kenshi gashoboka kuko turabafite benshi bahura n'icyo kibazo ugasanga ari ihebye ariko nk'iyahuye nawe ukamuhumuriza ukamwumvisha ko ubuzima bukomeza arakomera rwose kandi akumva ko ari urugendo agiye gukora kandi agomba kuzarutsinda tuvuga ko ari urugamba kandi urwo rugamba tugomba kururwana tukazarutsinda sosiyete nyarwanda rero rwose kuba hafi y'umurwayi wa kanseri bakumva ko nawe ari umurwayi nk'abandi kurwara kanseri ntabwo bivuga gupfa ufata imiti rwose ugakira ubuzima bugakomeza ukagera ku iterambere wifuza murakoze cyane sinzi niba nabasubije
murakoze cyane yeah now we moving to we see the perspective from the patients. So let's see now the perspective for the volunteers, people working with patients every day. And I'm going to introduce Darius Benimana, who you are a medical student. And part of your bio, I read that you face yourself, not you, but someone of your family suffer from cancer. I think you have tangible experiences. But the question is, for someone who has worked closely with the cancer patients, and you have your own experiences, what coping mechanism have you observed to be particularly effective?
So thank you so much, Christian, Doctor. My name is Darius. As he said, I'm a medical student at the University of Rwanda. And I have worked many times with cancer care organizations and now I'm working with Mid Cancer Initiative Rwanda. Reflecting back to the problem you're saying, my grandfather died because of cancer, and it was a most worst thing I ever had in my life. Having the information that he suffered from cancer at a late stage, there is no reverse reaction, there is no reverse mechanism of treating her. So I get the very serious problem, and getting that my grandfather is going to die, and he was one who was taking care of me. So it's so very hard, but if you were challenging with that problems, you have to consult people who can think, who can get your problem you're facing, who can advise you what to do. It's the most thing that can make you being a brave. And now I've made myself to give support to the people who are facing the problems like what I have faced. Thank you so much.
Thank you, Darius. Another question. You mentioned about your personal story, but I would like to know, is any resources available to support mental health during the cancer journey? Do you see any resources available, part of your journey, part of your experiences, which can support mental health for cancer patients?
Yes, I can speak that in two perspectives. The first one, we have people who are facing cancer in their everyday life. The doctors will speak more about that, the problem that they face, the challenge that they meet. But we know that the Rwanda healthcare system is being sectorial. We have people in mental health who are treating people who are experiencing the problems, okay? And within oncology, the oncologists are being trained to give a palliative care to the families and the palliative care to the person who is facing those late stages of cancer. So in Rwanda, we have resources, we have workforce, we have facilities, we have rehab centers, which are all working to promote mental health among the cancer patients. Thank you.
Thank you, Darius. So now we have a patient perspective, you have a volunteers. Now let's move on a clinical side. We used to hear that cancer, it's a death sentence. I don't know if Dr. Diana will say yes or not. But my question is, what are some common coping strategy patients use to manage the emotional challenges of cancer? Because I know you meet so many patients in your daily practice.
Thank you very much, Dr. Christian, and thank you for this important topic to talk about. And I'm going to talk about cancer and mental health on the perspective of a clinician who meets these patients every day. First of all, I think we agree with everyone, even the person who, Madame Edilene, who talked previously, that there is a huge emotional impact of cancer diagnosis on both patients and also their families. Now, this, it depends. It's individualized because it depends on individuals' experience with both the medic and also the surrounding, okay? Now, if you try to link these two, I find it like we have two main causes, if I'll start from there, before talking about the coping mechanisms of these mental health issues that may manifest as depression, anxiety, sadness, name them all. Now, when we talk about stigma that really, triggers these mental health issues, I'm going to give you an example. And I'll ask any clinician who is here, if we have a patient who has an end-stage cardiac disease or an end-stage renal disease, how do you call this particular patient? Any clinician here, internal medicine? The patient is called Mr. John. How do you call him? Any clinician? Is there a specific name that we give to this patient? No. Okay, maybe when he enters, you'll say, Mr. John, welcome to my clinic. Now, I'm going to ask Dr. Jerry. We have a cervical cancer patient, stage 1A. Is it curable or non-curable?
Very curable.
Okay, but thank you for that, Dr. Jerry. But from the time of diagnosis, this stage 1A patient is called a survivor. That's a definition of a cancer survivor. Now, this means this patient from the let-go, she's not going to leave, she's going to start surviving. Now, imagine every day, you don't know. For me, surviving means the next day you don't know if you're going to make it. But as you've heard from an expert in this field, it's curable. So that's stigma. And if you have a patient who dies or succumbs to cancer, they'll say they have lost the battle to cancer. So these are some of the terminologies that we really put there, but really triggers the stigma that these patients face. Two, if I'll talk about the coping mechanism, now going back to the question that Dr. Christian has asked, it depends really. As I've told you, on a personal basis, when you listen to the patient, it's more of them going to, talking to families, talking to peer cancer patients. But there's nothing that will say that it's in the system there that's helping them nationwide. Thank you.
Thank you, Dr. Jan. I think terminology matters, and sometimes I'm asking my oncologist colleague why you call patient a cancer patient, not a patient with cancer. Why we need to associate cancer with the person, not associate the person with his dignity and humanity and say cancer patient instead of patient with cancer. But I have no answer, I'm just open the floor. So second question, are there any specific factors that makes individuals more resilient to the psychological impact of cancer diagnosis from your experience?
I would say it depends on the upbringing of this person, the experiences that the individual has had previously. Because again, when you see this patient every day, they're on different level of this impact of the emotional impact of oncology. And I'll also talk about the systems. Yesterday they talked about systems being the key thing to solving most of these problems. But the systems are based on subsystems that are interconnected. Now, the resilience might come from a patient who had had a working subsystem that had helped her or him in psychological, support throughout their disease journey.
Okay, thanks, Dr. Jan. So we move from the patients to the community level, we move from the volunteers, we now on the clinical services and perspective. Now let's move on policy stakeholders. Dr. Darius, from your experiences, I know you have so many experiences on psychology, and I was even lucky to read about your thesis on your PhD, which is, I think, one of the best we have. So could you shed some light on the psychological impact of cancer diagnosis on patients and their families? Yeah, thank you.
Thank you so much, Dr. Christian, and thank you, IRICAD, for inviting us in this conference and organize specifically a session about cancer and mental health. I think the journey, the cancer journey is very much associated with times of stress, and I want to agree with my co-panelists about that. This is relevant for all countries, I may say, or treatment centers and in the journey. But in Rwanda, I think there is a second reason to take care of mental health because it's a situation that is quite common for clinicians to receive people. I will refer to a recent experience, someone having a breast cancer. She's a survivor of the genocide. She said she was the only survivor. And even at the time of diagnosis, for her, it's a death sentence for her. She said, I was traumatized the first 10 years. I tried to rebuild my life in the next 10 years. And then today when I have a job, children, husband, I will die soon. It was even not yet, the diagnosis was not yet provided. So she said, literally, I'm making my children orphans again. So feeling guilty, and it means the journey of cancer is associated with, at different levels, associated with shock, sadness, frustration, anger, bitterness, upset, worry, anxiety, etc. And at different time, at the diagnosis, when people have a medical appointment, waiting results, at the time of treatment, a new treatment, and if there is a colleague, death of a colleague, and even at the date of anniversary after treatment, to say, this is the time I was about to die, will I celebrate my next anniversary? All the journey can be associated with so many challenges, but as we heard from Marie, she also mentioned being helped in the journey and become resilient, the personality. She said, nimara kubyumva byarangoye cyane, but I kept having hope. She had children. She kept thinking about children, the colleagues, and the boss, and neighbors, all constitute protective and resilience factor to be reinforced. And maybe I talked about the patient, the family members, but also health professionals. And I just want to quote a paper published by Dr. Cyprian and Fidel Sebahungu about health professionals. You get really affected when you announce such a news. Nothing else we can do, but you can prolong if you have this and this. It's so sad. We need the brief session.
Thank you, Dr. Darius, and we are lucky we have the author of the paper here, Dr. Cyprian. Yeah, so Dr. Darius, how do you think we can, healthcare professionals can address effectively the issue of mental health for cancer, during the cancer journey?
I would say it is also related to the mental health system. Mm-hmm. And allow me to say that after 1994 genocide against Tutsi, Rwanda had 0 psychiatrists, 0 psychologists, 0 mental health nurse. But over the last 30 years, the country invested a lot, and there are notable progress. We have currently 16 psychiatrists, 500 mental health nurses, over 1,000 of psychologists, deployed in the health system. So at the level of diagnosis, I would say teaching hospitals, all teaching hospitals and referral hospitals have a department, a mental health department staffed with a psychiatrist, a psychologist, a mental health nurse. So they support the journey, and we also have a mental health unit at the district level that is staffed with a psychologist, and most of the time 2 psychologists and 1 mental health nurse, or 2. And currently we are about 400 health centers in Rwanda are staffed with a mental health staff. So the staff can support at the level of diagnosis. And in treatment center, I would say some treatment center, we can refer to Butaro. They already have psychologists in the system, a psychologist for children, for adult ward, and they do the screen, especially for depression and anxiety. They provide pre-chemotherapy counseling. They also support family members, especially they have a specific group session for parents, for children. So even at palliative care level, but I would say we need more integration, because sometimes you have a service that is decentralized, but not linked in terms of protocol, staffing, and capacity building.
Thank you, Dr. Darius. I like what you say about hoping, but just a quick one. Is hope a strategy in cancer care and mental health?
I would say hope is a result
Okay.
of a number of factors that need to be in place, and that hope help to do the journey.
Thanks for the question. So let's now turn to our audience. So we still have a few time. So if you have a question, just raise your hand and then introduce yourself, just your name. And if we have a specific question from one of our panelists, we have a Professor Reyes online, we have a Dr. Diane, we have a Darius and Dr. Darius, and we have a Wize survivor. So let's start on my left.
Thank you very much, panelist and moderator, for a very realistic and informative discussions. I have two questions. One will go to Dr. Diane about the stigma and those naming of the people suffering from cancer. I need to hear from you, how do you perceive the attitude of a medical team or professional team handling these cases? My concern is that also part of the team and partners, including oncologists, nurses, and everyone that is contributing to this, they start to treat a cancer patient as a dead person or just a very sure potential dead person, that the attention will not care about their emotions and sentiment. So how do you assess that? And what do you think can improve that attitude? Because the attitude of the victim or even the families of the victims are most of the case implied or called by the attitude and the action and the response of the team that is dealing with the case. My second question goes to Professor Jacques about the contamination or the pollution, air pollution and the other associated with the toxicology and the toxicity of the environment and the effect it's having on cancer. I think as we have been discussing throughout these 2 days, there is a need for strong system. How do, as medical professionals, cope with overall leadership and regulators? I'm saying this because if the way the world is moving, economy is priming on regulations, and the regulators are losing their consideration vis-a-vis profits. And innovations and technologies as they grow, we are ignoring part of regulation and enforcement. How do you, Professor Jacques, perceive the extent to what our policies and regulations address this issue? And how do you rate the enforcement of these regulations, even those that exist? Thank you.
Thank you for the question. I will ask our audience to be brief, precise, and concise to the question because of time. Yes? So let's take 5 questions, so then we'll respond and then conclude. Yes.
Thank you very much. Can you hear me?
Yes, we can hear.
Thank you very much for an excellent presentation about something that's really dear to me. First of all, I would like to congratulate Uwizeye. Well done, and keep it up. Now, one of the things that I would like to address is the terminology of survivor. I am a breast cancer survivor, and I'm very proud to be a breast cancer survivor, just like a genocide survivor can stand up and say, I am a genocide survivor. And it's a double whammy when a genocide gets breast cancer, whatever, and we appreciate the support given. Now, My beef comes with the communication between the clinician or the physician and the patient. That's where all the problems begin. Recently, there was a training given by some of our fellow African oncologists called cancer language. There has to be some training for the caregivers who give cancer treatment.
Can you summarize the question,
Yes,
please?
so please, and I have to speak about hope. Hope is the link, is the essence of what a patient or a survivor holds on, because we don't have AIE yet to make sure that I'm going to get well. But when you have hope, that's why she got well. That's why I got well. So please, let's all work together and find out ways to deal with the problems that we have. Thank you.
Thank you, Philippa, for the comment. Another question? Yes, please. Can you introduce yourself and then
Yes.
go straight to the point?
Thank you. My name is Charles. Mine is about the guidelines, the treatment guidelines, integrating this element of psychological and emotional package. I have had experience of a patient where they were flown out of the country, and 2 weeks before the actual treatment started, they were on the psychological and nutritional package to prepare them. But I've noticed that in most of our countries, we are they start the psychological package when the patient is already weak, the treatment is already affecting them. So I just wanted to check if there's thinking around having this integrated into a treatment guideline for the cancer patients. Thank you.
That will be for Dr. Darius. Another one, yes?
Thank you. My name is Ruth Tuisenje. I would like to ask about the cost of treatment of cancer. Sometimes you can meet the patient with cancer at the community, the poorest mothers or other patient. When we talk about, we give them the advice to go to the hospital, they can tell you it's very cost, and then we don't have the support, and then we don't have the money for the treatment. I would ask if you have the plan or how you can reduce, I don't know if to reduce the cost of...
Strategic plan to reduce the cost of treatment.
Yeah, the treatment to help the poorest in the community to have access to the treatment. It's my question. Thank you.
Thank you. Yes. And then we'll take the last question because, Dr. Spree, yes.
My name is Aisha, palliative care coordinator in an organization named Al-Amal. Okay, as you continued to say, patients need to be cared for at home, and they only go to the hospital when there is a service that can't be provided for at home. Is there a plan to increase the hospice all home care programs, since it is obvious patients need them? For example, sometimes you find some patients can't go back to the hospital due to the financial difficulties or poor understandings of their diseases.
Yeah, thank you. Thank you for mentioning about palliative care on that. Yes, Dr. Yes. Then Dr. Spree will be the last. So I will ask panelists to just in brief respond because there is another session behind us. Thank you. Can you switch off your mic, please? Thanks.
Okay, thank you. My name is Manka. I work for WaterAid East Africa. I have a proposition.
Okay.
I look at the level of trauma that cancer brings from the moment the patient is given the news throughout the journey, and I refer to the reproductive and child health clinic setting. When pregnant mothers walk to the clinic, they have RCH education session to take them through the journey throughout the pregnancy.
Yes.
Can that best practices be taken to cancer care and treatment centers? I think it will really help I'm talking about this because sometimes you'll find someone is going for a chemo at a stage when it is very expensive, and those medication are not there.
Yes.
So you have to go and find money to come and pay for that service when it is not available. Or somebody needs blood and it is not there, and you have to go and mobilize. So looking at the mental trauma that the patient and the caregiver leaves the facility with, I think it is too much. Can that be integrated in the healthcare management setting for cancer?
Thank you, Marka, for your suggestion. And our last question to